My plenary lecture is actually on reducing feedback. So I don't want to anticipate too much on that because you will hear for 20 minutes me speaking about that topic. And if you don't mind, because I'm the co-chair of the Kilifi County Health Stakeholders Board. And I've worked in other counties and I know the mechanism. Number two, what are they doing? Because as it happens everywhere in the world, you can have a country or a county where maybe, 10 partners are working on maternity or on infection or something without knowing what the other one is doing. And it's not a pilot system. Our staff pilot means the pilot then disappear. And we are all, we have enough pilot license. How can we make what partners are doing really the person of the government policy and who sets the priorities? That should be very clear. It should be, and it is in this form, it is the county government who sets the priorities. So if maternal health is a priority, then partners are invited to work around that topic to get it right. So we are now about position for me, I think that when we started maybe 80 partners, but not clear who is doing what. So we have tried to organize it. I think we are 30 major partners. And they are all together, led by Brazil, led by the department, and we as partners, we meet once every quarter. So then we have 6 technical working groups on these topics. Infections, RAMCA, health systems, finance. The 6 technical working groups, they have a chair from the county, and they have one of the partners coaches. So they bring their findings and their reports so that everyone is aware and that we don't duplicate too much. If a new partner comes in when he wants to go out, please make sure that you know there are already 3 groups, 4 groups working on that, and that we coordinate. And I think that has really thanks to the leadership of the county, that has improved a lot. But more needs to be done because we still work a bit, we come with our own agenda as topics from everywhere. We try to do our own thing, but we really need, I think for me, county leadership is key. It's the county who should decide what are our priorities and inviting partners to take the votes, to help them to reach this priority, not the other way around. So we have these 6 technical working groups, and I think the achievements of the last year is really that we don't come to 6 working groups and just say 1, 2, 3, 4, but as we ask the county government, tell us for this year, what are your top 3 priorities? What should we, as parties, stakeholders, what should we do? So I think that's the way to, because sometimes it's difficult for me, but how the Kilifi County health stakeholders functioning and how we are partnering for that.
It's such a valid point that we're moving away and Kilifi County being very good example from at the same well communicating to each other. We've moved from 8
government. So we were asking, at that time, 2017, what are the priorities for the government? He asked, please write your plan. Then, blinded, asking the health community, the research community, what are your 10 research topics you're working on? Is there any alignment? First thing was they didn't know each other. Very little communication. A lot has changed. But the number one at that time, priority was road accidents. Not one researcher was working in that area. Of course, there were alignments. There is some of them conflict, they knew each other. But so what has happened in many years is that there is really an improvement on knowing each other, knowing where to get the data, knowing how to use it, and working together towards one.
I think, as you say, it's inclusive, and returning to the audience for questions after this. I want to hear from funders. Academic institutions are always meshwork of ideas. What would you say is the opportunity for innovation from where this started? And I want you to focus on community solutions, right?
So many areas that infuse into the whole spectrum of healthcare. The fields which we started the system for medical services, medical care, community care, but we also contribute in terms of the training that we give to students. At one university, for example, we train nurses. We have nursing students who go back into the community supporting healthcare workforce. We train the medical students, their public health, food nutrition and dietetics. So in our view of health and health coverage, we are much more not only in healthcare financing, which is about healthcare coverage, but we are bigger than that. And from the keynote speech, I think it was very clear that the greatest win for this struggle for healthcare will not be healthcare financing, but in health promotion and prevention. Probably if I ask the audience how many of them have woken up in the morning and had a run or a walk, only one. So you cannot win it by waiting to get sick so that you can have health coverage. You must prevent that sickness. So we should not wait till we get sick. I think the next conversation should be, how can the county contribute to us not getting sick? I don't want to be sick so that I can look for a shot. Thank you.
Thank you. I want to turn to the audience. Yes, one of you.
I wanted to react on the audience on the issue of where the community is thinking. One thing that has happened, I think, in the last few years is there's been a lot of what we call civic engagement through various processes, through our planning, our work plan never goes through without public participation. So we walk through the community in this. Again, there are quite a number of civil society groups working in the community. It's amazing the number of memorandums I get in the office about health issues that are coming from the communities that are involved. So there's a lot of community engagement in the process. But I also want to mention another issue about private sector engagement. I think one of the challenges we have with the expectations from the private public engagement is that the private sector is
this question, the burning question. We really do want to hear from the audience, not just from the panelists, because again, for us to be seated, it's because Kilifi is a model. We've heard from all the panelists, right? There's goodwill. There are partnerships that are working. There's community involvement and community ownership, right? But it's one thing to say when you're seated on stage, it's another to hear from you. So if you have comments, feedback, or a question, we do welcome you. We have the Honorable Governor, we have public sector, private sector represented here. What do you want to see? What have you been hearing? Or if you have a direct question. Anyone with a question? One at the corner. I will come to you.
Thank you to the panelists for your
And your name, introduction, Daktari?
My name is Nancy Aswanda. I am based at Kilifi Symposium, and I am the panelist and chief I have a question regarding anyone can answer concerning innovation around based on about born and one thing about what the student has been in county relating to that kind of situation for what support has been available in the county.
Yes, my name is Patrick Oyaro. I work for Kilifi Health, USA Established Planning. And thank you for the presentation and the panel. My question goes to the academia representing the universities. How are we ensuring that the school projects that the students are doing speak to the situations or the issues that are in the county? And to what extent do we collaborate with the Department of Health, for example, so that those projects can be meaningful and contribute to the improved outcomes of the people that we serve? But then also, I can give myself an example that I trained as a doctor, but I was never told about procurement and commodities, and I was never told about AIE. And as soon as I came my internship, I was posted to a facility, and then instead came with something for me to sign, and I didn't know what to sign. But the question is, how can we integrate some of these things to the students before they graduate? The last year of the graduation, we introduce these things so that when they come out there, they already know that issue.
Thank you. Let's take those two first. There's a question on private capital. Yes. Yes. Blended financing has not taken shape in this country, simply because it's very difficult to structure. Healthcare is very interconnected, extremely complex. How do I quantify for students? Is this as simple as that? How do I quantify so that he is covered under the county arrangement in this, and if an individual comes to the blended financing? So part of what variances in the development of the infrastructure. The dollar at the time was also misbehaving, that wasn't planned for. Then going about these projects are a very mega time-consuming process. National government is very supportive. Through partnerships, but look at the public-private collaboration. We're working closely with the Ministry of Treasury, the National Treasury, to figure out how to tailor these instruments and these financing mechanisms on the healthcare sector. Because sometimes in healthcare, in fact, a lot of our capital is not for things, it's predominantly for people. So how do you then structure that? So to be honest, there's been none that has actually taken shape. I've always been very mindful about it really active. So I know there's none actually that has happened, but I feel that that will be an offshoot of the work. So I'm really looking forward to that because sustainability at the end of the day is something that you are looking for gratitude and to helping this and this. And I just wanted to contribute to this conversation. So I've done an MBA as well, and I think it's very useful. And I also am the head of department at the medical school. So I absolutely agree with him. It's something that needs to be integrated, perhaps as an education ministry, because in healthcare we sit in all sectors. I mean, for me myself, we even go to court as doctors. So I would suggest that it's high time we figure out what universities are good at doing in MBAs like Transform, and figure out can we co-develop a finance module that can be done in the final year, because at the end of the day, it's a benefit to the individual, it's a benefit to the institution, it's a benefit to the country. So that we're already developing managers before they even step into the management.
Thank you very much. I think you're talking about localization of training, and especially medical training, whether medical practitioners and medical other things. I think we have to be very particular in terms of what the curricula are different for different professions. If you just do medicine, you will be good and excellent in medicine, but not in geography. You want to be good in medicine, and then you are good in procurement, you are good in communication, then others will start somewhere and go somewhere. It will defeat the same purpose of this inclusive kind of conversation that we have. But I get your point. Everybody normally has a kind of thing, but the structure of the training normally is for professionals to know more and more of less and less of that profession. Managers are the ones now who are supposed to know less and less of everything. So you can't be both, you have to choose. But we try in terms of integration, we really try. We try in terms of attachment. We take you to attachment so that you can see how others are decision-making and seeing this. You can be able to see and learn from practice. With field trips, we take you for field trips. We also take you for internship so that you can be there for a longer period of time to learn what others are doing, how to write a memo. You know, even doctors are in there. In the difficulties writing memos because they are not taught in English and how to write a formal. They are only taught to write those short and very interesting handwriting. These are the chances.
The one final question was, as I asked the panelists to prepare one sentence, what do you want to see in 2026 done differently?
My name is John from Florida. We were discussing something that came to my heart, which I think health comes across to everybody, ordinarily. So it needs to be tackled, as Rob was trying to say, to prevent and counter mistakes. But again, doing research is also expensive as a student. Right now, I have a project. I'm very much interested in health issues. I'm a sociologist by profession. But I've picked up a project that I've worked for the last 5 years to make sure that I'm bringing a supplement that is
that research students can be supported to make sure that they are doing this research and the community studies. Thank you.
Thank you for that. I think that question will be addressed in one of the closing remarks. And with a sense of Benjamin, you address that as you give us your closing remarks as well. What do you want to see and then address the question?
Good, thanks. Very, very briefly, I think really, really good answer. Thank you for moderating panel, but also to the organizer for inviting me here. In conclusion, there's a lot to say, and I'm looking forward to the conversation over the next 2 days. But really, for me, my take home from Noel, like a good student of mine, is really, and a key point is really what I would hope to see moving forward, is taking health beyond medical services. And this is really, really important in both in framing, but also in the decision making and the choices of investment, is because medical services, as you like it, hospitals are like garages. And you only go to a garage when your vehicle has broken down. And I don't think we are all living for our vehicle, which is our body, to break down. We actually want to avoid those garages. So health is made in the domain. So they need to rethink about how to focus more and strengthen more about preventing us from going to the garages, which will include then shifting a bit of the model of even resource allocation prioritization, investing more on prevention, primary care, and diving less into your kind of high-end. And I know why sometimes we do focus on medical services are very personal when someone has stage 4 cancer. It's very personal to me and my immediate family, and it's a very, very difficult. But actually, a small intervention, say, improving the ongoing HPV vaccination, will prevent that big catastrophe that we face. So I think moving forward, we want to see us more and more investing more, and because the resources are not limited. And for us to be able, we will not be able to continue expanding the resources for health. So to get value for money, we need to start investing more in prevention at community level. My last point is what we want to get forward is us being able to expand the decision space through both capacity building and empowering of our practitioners and service providers and facility managers at sub-county and county sub-county level to give them the capacity to make decisions, including of the resources allocated to them. Because that tiny additional decision space can actually mean life and death situation. Once we empower them and facilitate them and capacitate them, I think that's really important. My last point to go ahead. I completely agree. I don't think I can give you more. I think there's I'll end my talk with a quote. I use this a lot in many forums. It's associated to one of the governors, in Nigeria. And it's very common, it's called very well. He says, health is too important to be left to medical practitioners alone. Health is the business of everyone. It's not just the business of doctors and medical practitioners. So I completely agree with you. Health is the business of everyone. It's our quest to leave no one behind. We need to involve and engage everyone because everyone has a role to play in asking health. Thank you.
Thank you. Peter, any call to action, final remarks?
My call to action actually is when we are looking at health, we need to look at the behavioral aspect. The health-seeking behavior of our people, the attitude. I think the decision to seek health is very important. That is why health-seeking behavior becomes very important when we are looking at this matter. As we are saying, health is not just medical. There are many aspects to health being. Physical, social, and all cultural issues that are intertwined that we need to see strengthening CHB facility linkage. That is very important. It is the community health strategy book that needs to be followed. And finally, something else that we need to see happen is that we need to activate community structures. We talked about there's something called village committees, which sometimes are not functional. And this needs to be structured so that we can have structured dialogue at community level led by community health volunteers. Sorry, that name has been changing for many years. Community health workers, community health whatever. Now we are talking about community volunteers. The providers, promoters. So from volunteers to promoters. Probably again some years to come it will change to something, I don't know what. But finally, we as Helen Keller, my call is that the county government that now, Your Excellency, you are here, you continue strengthening the partnership and coordination at the county level to ensure that meetings are predictable and partners can work together as a team to ensure that we are leveraging our resources together with the county resources to ensure that communities and mainly children and women get the services that they need. Thank you.
When I talk about yes. When I think about it, I think of three words. I think of healthcare ecosystem approach. I think one of the things we have not done very well is the multi-sectoral coordination and working arrangement. National, county, other counties, within the county itself. So how do we, because I think about, for example, adolescent pregnancy. Is the Ministry of Education involved in this conversation? Because by the time they're pregnant, they are the healthcare bodies. The healthcare system then handles that. But how do we reintegrate them into the education system so that they don't continue to have children at a young age who also become a burden to the system? Have we worked in the correct other sectors to support this? Number two, I think about sustainability. The priorities that I was talking about. I think Kenya has done it. We have done the sandbox, we have proven we can do the work, we are capable, we have taken global agencies in charge of our projects. Can we now talk about sustainability? How do we make it part of sustainability? Looking at finance, human resource, capital, technical assistance, and other ones. And finally, through very supportive leadership and governance. Through structured frameworks, depersonalizing this work and institutionalizing it more posterity. And that way we bring and push forward.
Just to stay online with what you were saying, I think the health is at the root and diseases in the but we have to call for more investment in prevention. What Cory was saying. When we have done all the prevention, then you screen for cervix cancer, but then there's no way to go for treatment. You screen for symptoms, but there's no treatment. So I think we cannot just say we have to make sure that there is a lot of investment in prevention and good health and so on. And also the facilities that have to grow at the same way. Number two, like I said already, I think that the leadership, the governance of the private government is so important. The health sector, but all the other sectors together, and I think we're doing quite well, bringing them together. Simple health, pregnancy, there was a task force still there, bringing the health sector, the generating life, the education, everyone will all come together and work together. So I think that is important. Another thing that I want to say is we are now in an age of technology and very rapid AI and other evolutions. And we should embrace it, but be sure how do they really contribute. Because many of us have not been raised with this technology. So the young generation will help to integrate it. But we also have to look at what are the dangers. Because we see, I just was told from UN agency that Kenya is the number one in terms of presenting themselves through media for citizens. So I mean, Nigeria, Kenya, this is kind of how do we handle it? And then the last one, I think, I'm not sure how many in the audience are below 25. Here, maybe you raise your stand. But in Kenya, youth is defined up to 35, so maybe 35. Stand and raise your hand. There are not that many. So we talk about a country and a county with a lot of young people, and we talk about this symposium. So we should do our very best to evolve, to improve also in the stakeholders forum and wherever we are, to really have the voice of the young people. Because of this.
Thank you very much. Like I also very brief, what is supposed to work is not there. So I'm the privilege. For me, 2026, I want you to call us to discuss about why we should not do this. So that we don't know what is part of this. I think nobody wants to be sick. Who wants to be sick here? No one wants to be sick. Why are you discussing with the government? So you are already sick. That's my number one. My number two, we need to expand the definition of health. The definition of health has expanded. We are still silent. We are still narrow. Just focusing on our way to science. Open it up. Spirituality is medicine. So you have to hold your Bible, you have to pray so that you can have spiritual peace. Social well-being is part of it. Mental health is part of it. We should not be sick and start, pressurizing government to provide this. We need even the hospitals to go down. We don't need more hospitals. We need more physical facilities to do exercise. We need more food. We need water so that we don't get sick. I don't want to get sick. You guys don't get sick. I don't want to get sick. Finally, sustainability will only be sustainable in health when we do prevention, when we do promotion, not curative. Curative is very expensive. That's why we are struggling with share, with billions of money that could be invested in increasing the well-being and welfare of the people. By now, we have to use it to provide drugs and to provide medical facilities, medical equipment. We can reduce this. It is a decision we have to make in 2026. It is a mindset change that we have to make. You have to wake up very early in the morning, hold your Bible or Quran, read, pray. You have to exercise after that. You have to dance to music for emotional health. How many people danced yesterday? Only one. Thank you very much.
Thank you for the comment about protocol. Before you get up, your group photo, but a comment just also to your excellency. I think from what you've heard from the panelists, each one of them has been started. They say Kilifi County is a role model for other counties. And we want to say congratulations to you and your team and to all of you. And we'll bring us to our group photo and one on video.
Thank you very much. A big hand to the wonderful panel. Mr. Peter, Helen Keller, asante sana, Dr. Noel Orata, our keynote speaker. Thank you very much. Professor Benjamin Sofa from Cambridge, thank you very much. Professor Malin Samaman, our chairperson of the Kilifi County Stakeholders Forum, asante. Professor Ali Mushauri, my good friend, Deputy Vice Chancellor. Asante, and a bigger hand to Dr. Diana for taking us through that. this particular juncture, I want us to quickly move into the official opening ceremony. I'd like to all be standing for the national anthem. National anthem. East Africa. Thank you very much. We have a Your Excellency, the Governor, Honorable Gideon Maro, Your Excellency, Mohammed Mara, the Deputy Governor of Lamu, and also the CEC in charge of health. Your Excellency, Honorable Peter Barogo, the CEC for health. Professor Ali Tamaman, the Chairperson of the Kilifi County Health Stakeholders Forum, and all the partners present, and all the partners of the plan, the other by Professor Limu Shauri, and also Professor Chima Onekwe from Africa International University, research institution joined us here, led by our very own Kembu Welcome Trust, represented here by Dr. Sophie Yoga. Students, ladies and gentlemen, partners, good morning. I wanted to acknowledge those protocols and everyone else who will stand on those. Allow me to very quickly invite some key people to make very brief remarks as we look at starting off this particular one. Allow me to invite Dola, please take your seat here. Dr. Hassan Lely, please do take your seat. Dr. Sophie Yoga, please do take your seat. And Professor Malin Tamaman, please do take your seat. You will have a minute each. Kitole, you will do reflections on the research symposium. Hassan Lely, you will reflect on the county government of Kilifi and where we're going. Malin Tamaman, Professor, you will reflect on the role of the stakeholders forum, which you chair. And our good friend, Dr. Sophie, will reflect on the ongoing relationship that we have with Cambridge. And yeah, please, let me start with Ben.
Thank you very much. Thank you very much, Your Excellency, Governor Kilifi, Honorable County Executive Members, distinguished guests, researchers, musicians, and policymakers who are here. Good morning. On behalf of the Research Committee, I would wish to read this morning speech. It is my great honor to welcome you to the third Kilifi County Scientific Symposium. Today we gathered here not only to share scientific work, but to celebrate our national hero. A journey of growth, a journey of learning, and unwavering commitment to improve the health and well-being of our people. Our scientific journey health system towards leadership. That's inaugural campaign made a foundation for cultural evidence generation, evidence use, and collaboration within the Department of Health. Ladies and gentlemen, this year's theme will not only be voted, donor supports for various cushioned essential health programs continues to decline today. At the same time, the health needs of our people are expanding and becoming more complex. This moment calls for innovation, resilience, efficiency, and smarter use of evidence. Research technology counting is not an option. It is a backbone of a strong and responsive health system. Whether we are assessing maternal and child health outcomes, investigating emergency diseases, or evaluating performance of primary health care, or strengthening district alignment, or designing sustainability and approaches towards NCDs. Our work today must translate into informed decisions and better healthcare for our people in Kilifi County. Ladies and gentlemen, over the next 2 days we're going to be here, we will engage with evidence from within and beyond our borders. We will reflect on innovations that are strengthening services delivery at city level and community level. Also, we're going to reflect on strategies for improving immunization, nutrition, and other health services. At the same time, we're going to reflect on responses to the triple threats that our country is actually facing today. We're going to look at issues of interventional approaches to the rising burden of NCDs and lessons learned to operationalize primary health care in our community. I urge every participant who is here, students, the researchers, and the community, scientists, citizen scientists, and academics, actually to engage fully. Let's ask questions, let's share challenges, and offer new ideas. Research only becomes meaningful to us when it touches the lives of Najibu, Harissa, and Kaji. The adolescent seeking care, the community health promoter who is there supporting us at the community level when home to home, and the other citizens, and the elderly citizens who are living with chronic diseases. Research must be at the council. Ladies and gentlemen, this morning, let us this symposium reaffirm our collective commitment that every shift invested in healthcare is guided by evidence, and every policy is shaped by the data that we have. And every innovation is grounded in the real needs for our community. This year, we are not only going to have this symposium and listening to research papers, but also we are going to also gather dinner. This gala dinner. I want to welcome all of you here. In this gala dinner, we are going to celebrate good performance of continuous quality improvement in service delivery, where service delivery is good. Best performance is going to be recognized, they're going to be appreciated, and they're going to be rewarded. So that you can be able to motivate service providers to continue to improve the quality. Thank you very much for being part of the journey. I wish you a productive, inspiring, transformative city and the country.
Thank you very much, Dr. Hassan. Very few comments.
Distinguished colleagues, stakeholders, partners, and friends of Kilifi Symposium. Good morning. It's a pleasure to join you as open the Kilifi Symposium, a gathering that continues to promote
why we must focus our shift to strengthen our system from within. We must innovate in service delivery, diversify our funding strategies, and prioritize efficiency in the use of available resources. Research is a key enabler of this transformation. Evidence allows us to identify gaps, test intervention, scale up what works, and discontinue what does not. Across the thematic areas of the symposium, we see the heartbeat of mandate as a health department. And these priorities to the everyday realities of our communities, we must endeavor to make sure we deliver our mandate. I wish to extend gratitude to the researchers who submitted abstracts, institutions who supported them, and the direct committee that ensured the rigor of the symposium. Your work enriches our decision making and strengthens our resolve to deliver better health outcomes. Let us use these 2 days not only to learn, but also forge partnerships that endure beyond this event. Sustainable universal health coverage indeed becomes is possible, but only if we commit to innovation, collaboration, and accountability. Thank you all. I look forward to the knowledge that will emerge from our engagement. Thank you.
Your Excellency, Honorable County Executive Members, distinguished guests, researchers, practitioners, partners, students, colleagues, ladies and gentlemen, very good morning. I am happy to talk to you this morning as the chair of the Kilifi County co-chair, government as a chair, the Kilifi County Stakeholders Forum, and I've seen the evolution over the years. I didn't do the 47 county studies, maybe one of the students could do that or group, to assess the quality or the impact of the county stakeholder forums. I've seen a few of them. And I can say that as far as I know, Kilifi County has been stronger than the best Kilifi County stakeholder forum, bringing together all the parties, led by Waziri, of course, but bringing everyone together, not just to, as we did maybe a bit in the beginning, everyone telling what they are doing, but really putting it together to get people working and to come to a conclusion. Because, of course, I'm a researcher since many, many years. I value research, I value data, but I also see that data are there. How do we really translate data to impact? We call it data, we call it publications, we call it innovation, this is great. But what is the proportion of it that is really at the demand of the county, that is really needed by the county, that is a priority by the leadership of the county? And how can we work together really to increase, to leverage impact? Because this is still a big thing. We have publications, we do a lot, but how do we measure really the impact in this county, in counties in general? So I think the Kilifi County Health Stakeholders Forum is a strong mechanism. As I said earlier, we have many, many parties. Some of them have left and we don't realize, but we remain with a group of about 30 that are very active under the leadership of the governor and the Waziri to kind of guide us on what are the priorities for the country. And this is really our mission. This is why we are here, and I thank you very much.
Good morning, everyone. Your Excellency, County, Governor Namu, ladies and gentlemen, also the staff, good morning. On behalf of everyone, I'd like to first start by expressing deep gratitude to the
very much, colleagues and partners, and please do have a seat. Allow me at this particular juncture, please do have a seat. Allow me at this particular juncture to welcome Honorable Peter Morocco, the CEC Judge of Health, to pave way for the Governor. My name is Charles Kamau, I'll be the moderator and the head of partnerships.
Thank you very much. Thank you very much, everyone, for making it to this meeting. Your Excellency, Governor Gideon Maita Mungaro, first of all, it's my singular honor to thank you for agreeing to grace this occasion. I know your schedule today is very, very tight. But, you know, it's really a privilege for us to have the governor here, because I know the schedule is such that, you know, we were almost not very sure that it was going to come. But this means the commitment he has towards the health sector in Kilifi. So we really would like to thank you. But before I welcome you, I would like to ask, are there participants from other counties? Can you raise your hand? Please stand so that we recognize you. Participants from other counties. So before I welcome, thank you very much for coming to participate. Before I welcome the governor, I would like to acknowledge the presence of my colleague, CC. We were talking about, you know, multi-sectoral collaboration. So I have here the CC for education, who is here. So he's very much part of the so let's bring the people here before.
Your Excellency, my fellow citizens, Department of Health, all protocol observed, good morning. Good morning. My name is Quentin Lema. I'm the CC in charge of education, vocational training, and ICT, and innovation. So when you talk about innovation, I'm the father of innovation in Kilifi. I'm very much happy with you today. I think we have developed some data management systems for the Department of Health. We are also giving fortified porridge to those students in PP1 and PP2, that is part of the preventive measures. We have developed the emergency number for the Department of Health, again, 1535. You can use it. That is in my docket. We are also in the process of developing disaster risk management unit, which will be used for data sharing. So thank you very much. I'm not talk more. We are working collaboratively with the Department of Health. Thank you very much, Waziri.
Thank you very much. I would also like to take this opportunity to welcome the Deputy Governor for Lamu, who is also the CC for Health, Dr. Mubarak, who I know he has also a very, very tight schedule. He was scheduled to have a session tomorrow, but because of other duties, he will not be able to. So, but at least he made the effort of coming to join us. Welcome, Dr. Mubarak.
Excellency, Governor Kilifi County, Gideon Mungaro, Waziri Health, the Peter Morocco, all other partners present here, and friends of Kilifi, good morning. Consider that warm greeting from His Excellency Governor Isa Timami as well. I wish to take this opportunity to thank and appreciate my colleague Waziri Morocco for inviting me to this forum. I was passing on my way to London. I said I'll come and show support to this landmark event of yours. I congratulate you immensely for this great initiative. And Kilifi County is an elder brother to Lamu on matters healthcare. I remember back in the day when we did not have an ICU and Coast General was being Coast General. We always turned to Kilifi for support and they've never turned us down. At least now we have our own and we still collaborate on a lot of issues. I would like to distinctly appreciate the panelists who were here earlier and the aspects that they did. Dr. Noel speaking about the multifaceted nature of healthcare. And you know, as a person right at the top there, for our people, all they know about healthcare is dawa si kwa hakuna. Kama dawa hakuna, nyinyi bure kabisa. hakuna ili hakuna job. So the multifaceted nature and the complex nature of healthcare, there is more than dawa zipo hakuna. And I want to agree with Professor Benjamin when he clearly stated the gap that is there between data and decision. And I want to tell you that what is there is political goodwill. And I want to, put a special mention and, appreciation to His Excellency Governor Mungaro and my governor. At least I can, confidently say these two governors have kept healthcare at the top of their agenda, and I believe we do well. One of the solutions, as I wind up, I believe, is the two laws that His Excellency, the President, among the 4 laws that he pushed and enacted: the SHA, Social Health Authority Act, and the Facility Improvement Financing Act, which I believe NAMU and Kilifi are implementing fully. These are some of the strategies that will empower our health facilities to take those decisions based on data. If the money trickles down to facilities, then the administrators, who I want to believe most are medics or healthcare workers, who feel that maybe the biggest pinch from data, can be able to take those key decisions to be able to make a difference. However, we still have a long way to go on these 2 laws. One, for the FIF, there is a matter of it being complementary or a substitute. I think this is where we don't combat with finance people. They interpret it as being a substitute. We, in the health space, we interpret it as complementary. So then we get stuck. If it becomes a substitute, then you are basically commercializing healthcare, and it becomes a burden to patients. And then you have the other animal, that is SHA. So the always SHA inafanya ifanye. Haifanye. Hivyo nasema ifanye. So SHA, there are 2 aspects of SHA. There is the side of the patient, and there is the side of the health sector itself. It's supposed to be a two-edged sword in a good way. However, it may be working for patients on matters inpatients and surgeries. It is not working for patients on matters outpatients. It still needs streamlining. It needs more funding. But on our side, the health administrators and the leaders, we have a big problem. We are not getting paid by SHA. So how do we realize FIF if there is no money? How do you do facility improvement if there is no money? So this is what I share, 71 million. I go to give it up over 300 million. So all that money, if it goes to the facilities on time, then we are good. And I want to finally agree with Malin on Pan University that we are supposed to go the pre-pro way, prevention and promote pro, preventive and promote pro. However, we have a burden to deal with. We've neglected health for quite a while. So we have no other way except to strengthen our facilities to be able to deal with all the cancers that we have, all the high blood pressure that we already have, most of them complicated, etc. I wish to stop there. Thank you very much, and I wish you well in this initiative. Thank you.
Thank you very much. This stage, I would like to ask the audience to stand as I welcome His Excellency to come to the podium to open the movement.
procurement and supply chain management, enhance implementation of the social health insurance fund, and ensure equitable allocation of resources across all sub-countries, facilities, and communities. Our goal is simple: a health system that stands strong with the donor support lines. Kilifi continues to stand out nationally for meaningful homegrown innovations from digital disease surveillance and certain community health systems to emergency care models and grassroots partnerships. These are not theoretical ideas, they are real solutions. This symposium celebrates these successes and challenges us to go further, to scale what works, improve what doesn't, and invest in solutions that are Kenyan grown, evidence-led, and future-proof. Universal health coverage is not only about treating disease, it is about well-being across the entire lifespan. I think that's what Professor Shaul was saying earlier. This was right when we started singing the national anthem, that some of us would go away for the radio too. The thematic areas of this symposium: immunization, maternal and newborn health, adolescent care, family planning, nutrition, geriatric health, and even menopausal and proposal care remind us that UHC demands a holistic approach. We must also confront the persistent triple threat of HIV, gender-based violence, and teenage pregnancy. Addressing these challenges requires integrated interventions, community trust, and goal prevention strategies. I believe the conversations here will significantly strengthen our collective response. We live in a time of dual disease barrier, recurring infectious disease threats on one hand and rising and communicable diseases on the other. Our response must be preventive, data-driven, integrated across levels of care, and anchored in research and real-world evidence. This symposium provides a space where this sustainable model can take shape. Our strong primary health care system is the backbone of universal health care. India has made strides in professionalizing primary health care networks, but we must go further and faster. Our vision is a health system where every resident, no matter how remote their location, can access timely, affordable, and quality care without financial hardship. Your deliberations over these 2 days will guide how we invest, how we implement, and how we accelerate this effort. This gathering is not ceremonial. It is strategic. The research data and evidence generated here must translate into policy direction, budget priorities, program designs, and standards of care and facility level. Research without implementation is history. Research applied to transformation. I commend the Department of Health and Sanitation Services for hosting this symposium and position Kilifi as a home scientific inquiry, evidence generation, and learning exchange. As we begin the 2 days of presentation and discussions, I challenge each one of us to think bold, push boundaries, prioritize sustainability, build models that outlive donor aid, strengthen partnerships that serve our communities, and above all, keep the patient, not the system, at the center of every decision. This symposium is not just an event we attend. It is a milestone we advance together. To our partners, locally, nationally, and internationally, thank you for watching this journey with me. Your collaboration expands what is possible. To our organizers, I you very much for coming here. I want to do more than that. I want to say already about the position. I want to encourage you as we have started the festive season. After tomorrow, don't be down and spend the whole day. And we also, as we have been a lot of tourism, also on the health. We also target tourism. So, as our part of investment and the source of revenue for this country. You don't go into two nights. Don't find that one for one. And then you go back also, come back for Christmas. I wish you all a Merry Christmas and a Happy New Year.
Thank you very much, Your Excellency. May we now be standing for the national anthem as we close the official opening of the conference. They are now ready, Your Excellency. Only the Kenyan one, please. Allow me to now invite His Excellency to make a very brief tour to all the exhibition areas. Please, Mr. Chaburi, and the rest of the invited guests. So now, we are now breaking for tea. We will break for tea and we will be back here by exactly 12. We are going to break for tea and be back at 12 with the first plenary of Matana with the Child Health. Thank you.
hatukunywi chai. Are you presenting? Why?
Nafanya drill.
JPPA? UVT? Ama ya nurse? Zile clubs. So tutafanya pale mbele.
I don't have to salary in my bank account. Hi, how are you? I need your help. I am parenting a big bingo.
Mambulu, you didn't tell us to wear mambulu tunafanya. Tukakuwa amongst the others.
Ningekuja kusurprise. But I was waiting. I was waiting to surprise you. But it is surprise. This was surprise and then came into the
That's why I said I'm reachable. Where was you, darling? Nataka wangavaa viatu virefu alafu ananiambia ati siwezi. Alafu ananiambia wewe ni mzuri. Hi, Mite. Hi, my dear. Were you complaining that you don't have a blue t-shirt?
No. Mimi. I don't think we'll do today. Is it timing? I think it's supposed to be
I have to do it today. I've actually just arrived from Nairobi and I'm going back
you had told
today.
me.
Yes. That's why I'm picking calls and
You're flying?
my kids are
Oh,
all over
yeah,
the
it's
place.
holiday.
Yes.
As I mean, lucky enough, I had planned the weekend, your long weekend, yeah, trust.
Oh,
So at least.
actually I wasn't. It was a thing that I was told you can't not miss.
Yeah, I understand.
Sawa. Waendelee kunywa chai.
Amekunywa
sikudanganya.
kunywa chai afu amekuta mkono hivi.
Alafu she likes collecting evidence. She has evidence of me and Mumbo. Now today she collected another evidence. She just wants to be left.
The second one you didn't even realize. So you are gathering evidence upeleke nani?
Niachwe eti.
Na nani? Ushaona tall handsome Tanzania? Ache Mkenya. Hiyo evidence si mzuri. Bode yona. Kama na vianzo. Unda mkunywe chai. Ai, that is. Kutoka chai niyo inaudhi.
Hata mimi nataka maji. Mbona mko hivi glad?
Haki.
Haki I'm thirsty. Wacha nikuulize Gladys. Ale mbele. Kama wadosi watakunywa maji. Kenda nichukue kwa ubaya.
Go bring. Yani unachukua serious. Ulikuwa serious na kunywa nyuma leo.
Kile kuoga sana.
Enjoy. Wewe, labda kwa meka kati nzuri. Ungefikiria ni big. It was nice. She was very nice. Wewe.
Kuna time ilikuwa short wa hapa. Mwambie bwana. Mwambie aelewe. Rema. Moka ni reels. Mambo mtengeneze reels. Reels za Instagram. Mic in. Naona hapo. Kwa mic in. In mic.
Hiyo nywele yake. Amechange.
Wewe siku na kusanyia wote.
Kwenda wapi?
Kwangu. Hata mumelaani.
Tumelaani hata utapata imetoboka.
Siwapei.
Wewe? Hata umechange kama kusanyia. Maji ni hapa. Au mkao
Bali nimekupigisha.
huyo naye alikuwa mgeni kabisa. Daktari unajua huyo?
Najua tena tushaikata class moja I think.
Hajachange.
One, two, one, one, two, 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 one, one, two. Mic testing. 1, 2, 1, 2, 1, 2. Mic testing. 1, 1, 2, 1, 1, 2, 1, 1, 2, 1, 1, 2. Mic testing. 1, 1, 2, 1, 1, 1, 2. Mic testing. 1, 2, 1, 1, 2. Mic testing. 1, 2, 1, 2. Mic testing. 1, 1, 1, 2. Mic testing. 1, 1, 2, 1, 1, 1, 1, 1, 1, 2, 1, 1, 2. Mic test. 1, 2, 1, 2, 1, 2. Mic testing. 1, 2. 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. Mic testing. 1, 2, 1, 2. Hey, shikilia kweli na nguvu babu. 1, 2, 1, 2, 1, 1, 2. Mic testing. 1, 2. Mic testing. 1, 2, 1, 2. Mic testing. 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. Siko sawa? Usikiliza. Sikilizia hapa. Usikiza zote mbili. Nani nimeziweka? 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. Mic testing. Siko sawa? Sasa tunaendelea kuseti hizi. Kama uende uko mbele, kama unatumia hii utafuta uweke kana paka pale karibu. Lakini ya wish ukiwa na hiyo karibu ndio uone kenye una. Lakini hii haina shida na ukiwa mbali. Unaona hapa kwenye huko tu na kamera moja na sasa hiyo ndio shida. Sio ndo kuhamia hapa. Unaona kama uko sawa. Kuja uone. Kuja uone, angalia vile nimezoea. Huyo jamaa, wewe lakini anatoka. Anatoka ama aende pande ile huko. Unaona lakini jamaa kwa ukitaka unaona ile. Wewe bakia tu hapa. Buda, uko na kitu cha kubakia? Nilikuwa Kablada kadogo. Hapa hiyo. Ndio uko na kablada kadogo. Eh. Ama kama singte. Saidie. Tushikanisha vipi? Nataka kushikanisha pale. Hizi weights. Si magnetic bana. sawa mpaka hapo. Abu. One, two. Sawa. One, two, 1, 2, 1. Iko sawa? Iko sawa na hapo? Chonjo. Sawa.
option is we shift this one to somewhere else.
Nancy, let me invite you, Nancy. Let me invite you. Good afternoon, colleagues. Afternoon, colleagues. I would like us to continue with the second session, which is plenary one, and I want to invite Dr. Nancy Mongome, who is the chair of that particular session, to take it from here. Colleagues who are outside, please let us get back to the auditorium so that we can save on time. Karibu sana daktari.
Asante Charles. Welcome all to the first plenary session. Please get in.
Please let us maintain silence.
Thank you. Oops. Thank you so much, Charles, for introducing me. Welcome all. Those who are outside, please come back in. We're about to start with our first plenary session for this symposium. And our first speaker will be Professor Marlene Tamaman. She's been introduced so many times, so I won't go into the details of it, but she is the chair, Kilifi County Research Committee, the chair for Kilifi County Health Stakeholders Forum, and the Director Center of Excellence in Women and Child Health at the Aga Khan University. I am going to ask you to please put your phones on silent so that we can hear everything that's said here without interruption. Prof, please, karibu.
Thank you. A very good afternoon, sorry, to all of you. I think after this session you will have seen me enough for the rest of the symposium, I guess. But I was asked to, shall I wait till everyone is kind of finished the talks? Okay, let's try again. A very good afternoon and welcome to this session. I was asked shall I continue or do I wait a bit? What do you advise? I continue? Okay. So I was asked to talk about maternal and adolescent health, women's health actually. And my CV, as you can see here, I'm an MBS, very proud to be an MBS here in Kenya, and a medical doctor, OBGYN, and I spent most of my life in academia, in Ghent University, where I come from, University of Nairobi, Aga Khan University. I'm also the founding director of ICRH, but I made a switch in my career when after being invited by my friends, I accepted to run for politics. That was never the plan. But I did, and I became an elected senator in my own country. So I joined the Senate. And why do I say this? Because it really was for me a kind of complete new experience, but also learning that if you want to move something and you come from one constituency, it's very important to work with different constituencies, being public health, media, academia, communication, and also politics. And I want to take you back. Could we close the door a bit? The noise is really... I want to take you back. Learning from the past can help us to shape the future. This is the UN Secretary General Ban Ki-moon, and something that you might all remember being the Millennium Development Goals. We had 8 of them. The aim of the Millennium Development Goals was to eradicate poverty. And you can see, do you remember these goals? Sound familiar to many of you? So, after 10 years, Secretary General Ban Ki-moon decided to assess the progress made with these 8 very aspirational goals. And the one lacking behind most was which one? Millennium Development Goal 5. Saving mothers' lives was more difficult than anything else in the goals. So why was that? Because it has a lot to do with women's rights. The right of a woman to decide when she wants to get pregnant, with whom, and how many children she wants. So the UN decided to focus, to bring everyone around the table, not only the UN, not only the private, public, the governments, but everyone, communities, around one topic, every woman, every child, EWEC. Right now it's called, what is it called in Kenya and globally now? IWINI, right? You know IWINI, every woman, every child, every newborn. So, what was done? Everyone around the table, and it was successful, because one of the great successes of human history is indeed the effect on improving maternal and children's health. Did we improve? The goal was reduction of maternal mortality by 70%. We didn't get there, but we managed to reduce maternal mortality. And when I talk about maternal, very close to it goes stillbirth, goes neonatal, perinatal mortality, goes together with maternal. So we reached 40% reduction, thanks to a kind of a collaborating efforts of everyone. More money was put, because it was on a high political level. So remember what I'm saying. If you want to raise funds, if you want to raise attention, if you want to do anything, you have to make sure that your topic is on a high political level. And that's what happened at the end of the Millennium Development Goals. More stakeholders, more money. You can read the figures there, more global initiatives, more innovations, more research and everything. So, what were the lessons we learned at that time? What works? Political leadership and commitment. How many countries in Africa managed to reach the Millennium Development Goals and the number 5? Only 2. Those where the president himself at the highest level took the leadership. And not only the Ministry of Health, but everyone. Finance, education, all the ministries, parliaments, everyone was called around the table and was involved in moving the agenda forward. As we said already this morning, multiple stakeholder partnership, accountability, and what could work better. And the same, this is 2015, but it applies to today. We said this morning, what can work better? Country plans, priorities, coordination of existing initiatives, country leadership, reduced fragmentation. And we, stakeholders, donors, very often we work in fragmented situations. So, and now it's blocked up. So you will recognize some leaders in 2015. Our former president was there, and then Ban Ki-moon and others, who said now we need a global strategy, a new one, that brings us to 2030. A global strategy for women, children, adolescents. Not only focusing on surviving, but surviving, thriving, and transforming. Transforming what? Health systems. So we published a lot, and we said we know what needs to be done. Let's do it. We learned from the previous MDGs, so we can end preventable maternal and newborn mortality and stillbirths in 2015. Did we reach it? Are we there? 2030? Not yet. Far away. So what needs to be done? Strengthen care around time of birth. Health systems reach every woman and every newborn, harness the power of parents, families and communities, and improve data. So every country, and now I want you to pay attention to this, because if we listen to leadership everywhere, what is the aim in the maternal mortality rate by 2030? Do we know that? Somebody? Nobody knows? So, then let me inform you that the global, but pay attention, the global maternal mortality target is less than 70 per 100,000. Now, what is the Kenya government saying? Our goal is 70 per 100,000. No, that is impossible. Countries who come from a very high rate, so not one country should have more than 140. But we don't have to reach 70. 70 is global. There are countries in the West who have a maternal mortality rate of 10, 20. So the 70 is not the target for Kenya. Every country had a specific target. And I think the one, if I remember well, for Kenya was 149, based on the numbers we had in 2015. Are you with me? So, if you give a presentation, never say, we don't reach in Kenya the 70 per 100,000. We shouldn't. We won't. But that was not the target that we agreed on. Same story for stillbirths, 2.6 million. We are still there. Half of the stillbirths occur in labor. And that is an indicator of what? You know, all of you are in the field of maternal health. Those who know that you can have a macerated stillbirth, that fetus died during pregnancy, and then you have a fresh stillbirth. That fetus, that child is dying during labor. So half of them during labor. What does that show us? Quality of care during labor. Right? So if you have many fresh stillbirths, means your quality of care during delivery is in a problem. I was the director after my political years in Parliament. I moved to WHO, where I became the director of the Department for Women's Health and Research in Geneva. And there we worked a lot on quality of care. Now, two main interventions. If you want here in Kilifi to improve quality of care, you want to reduce maternal death, you want to improve maternal health, there is a lot you can do, but two interventions have really shown to be possible, to be cost-effective. That is number one, quality of care during labor. Of course, antenatal care is important and postpartum, but most women die when? During childbirth. So quality of care in labor is very important. And number two, what is the most cost-effective intervention? Family planning. And innovation is now in those times. So if your quality of care is like this, right, or like this, or like this, then you have a problem. You will have not the best optimal quality of care. And I'm happy that even the governor now, when he was going around, he told us about...
Which year was this?
Somebody wants to comment on this one? That's what we call in obstetrics gentle pushing, right? So now,
I'm sure the discussion is about how painful.
I know a lot of people are commenting on the picture, but I would like to move on. So remember, quality of care in labor, right? Number 2, family planning. If in 1 out of 3 deaths could be avoided, if women have the power to decide on their reproductive lives, if they have the power to decide, I want 2 children or 3, I don't want them one after the other, I want this care. So a lot of it has to do with women's reproductive rights. We did a lot of research, papers, modeling with the health economists, and it is really possible. So at the end of the Millennium Development Goals, we were saying no woman should die while giving life, no child dying of stunting, no newborn, but we see that we are still far away from the goals. Now that brings us to the new, where we are now, the Sustainable Development Goals. Many more goals, 17, many more targets, a much more comprehensive agenda. But are we doing well? Well, there is the unfinished agenda of the Millennium Development Goals, and then there are the new. In the Millennium Development Goals, we never talked about adolescence. We never talked about mental health. We never talked about NCDs. So the agenda is much larger. And then we had, of course, the COVID epidemic. We have now environment. So the agenda is much more comprehensive. But for maternal mortality, we know the causes of that, right? Everywhere in the world, we have the bleedings, we have the hypertension, we have septicemia. So we know the causes of maternal mortality. Why are women in Africa dying of that and in other countries less? Because, and you know, if you want to express it differently, 800 women die every day in pregnancy and childbirth. Imagine that 2 Boeings, 2 airplanes are crashing every day. It would be a big scandal. For maternal mortality, we even don't talk about it. So, let me quickly move. Now, the last thing about maternal mortality is that it's going up again. So at the end of 2015, we had reached some good achievements, but now it is so bad, going up again, that last year in the World Health Assembly, countries were asking WHO to renew the call for child survival. Now, looking at Kenya, what is the county, and you can all look in detail, where is your county positioned in the facility? I'm not talking about overall maternal mortality, but in the facility maternal mortality. Here you have the recent data per county. And Kilifi, I think, is number 13. But look at the numbers we are dealing with. The NMR, according to KDHS, is what? 355. According to the World Bank Group, a few years ago, 149. What can we say about these figures? They don't add up. So the county, if you look at the counties, most of the rates are around 160 per 100,000. Now, think with me, if 90% of your women are delivering in facilities, and the facility maternal mortality rate is around 160, can your country population maternal mortality rate be 550? No way. Even if all the women who deliver at home would die, even then you could not come to these statistics. So there is a big, big, big problem with data. And the president is very annoyed because every time he goes to UN and they are talking about Kenya is put up there as a country with a high maternal mortality, not going down. I don't believe these figures because the ones that we have for sure are the maternal facility data, and they are much better. So it's high time that something is done on this. It's not moving anymore. Yeah. So one of the great instruments that we are having, and I think Kilifi and also Mombasa, sure, and other counties, they are doing what? MPDSR. Now, MPDSR means that everyone comes together who has been involved in a maternal death or a perinatal death. Counties like in Kilifi, it's on a Wednesday evening, Mombasa, Tuesday morning, 100, 200 healthcare providers are joining. A very good presentation is made of the case, what happened, then analysis, conclusion, was this avoidable, what can we do better. So we have all this data and we should publish them. But even if you are there in the MPDSRs, today you hear about a mom who died because there was no blood available, and you make your analysis, great, action plan A, B, C, D, 3 months later you are in another MPDSR and you repeat. It's like a broken record. So what I'm trying to say is MPDSR is a great instrument. Action plans are often failing. We just repeat ourselves. And one of the, and I need another 2 minutes, one of the quotes that I want you to remember, to learn by heart, Professor Mahmoud Fatala, an Egyptian gynecologist, who was saying, women are not dying because of the diseases that we cannot treat. They are dying because of societies have yet to make the decision that their lives are worth saving. So preventable mortality is number one, childbirth. How many women do we lose every year in Kenya? 5,000 to 6,000. Most of them preventable. But there are other things. Cervix cancer, we talked about it already. HPV vaccine is great. What is the coverage of HPV vaccine in Kenya? 20%. In a country like Rwanda, 90%. Sorry to come back to Rwanda, but so it is possible to do it, but we need to work together, because we work together with the schools, with the health sector, with leadership. This is a thesis done by a Kenyan PhD student. I'm not going to read it. Just coverage is less than 20%. Even we have, in cervix cancer, we have everything. We have HPV, vaccination, we have the screenings, we have the early treatment. We can prevent women from getting cancer and dying. Still, we are not performing very well. So the system is unprepared for scale up. We work a lot with the Ministry of Health, a lot of meetings, but very little impact. And the other lady killer, so we had pregnancy, we had cervix cancer, and the other lady killer, and all of them are about 5,000 to 6,000 per year in Kenya, remember. So is breast. Breast cancer is very, very common. You can prevent it if you do screening with mammography, but we don't have the systems in place. So we are now preparing with new technologies, what can we do to have better diagnosis, maybe ultrasound, AI-enabled, etc., etc. So then a few words on the, it was already mentioned this morning, I talked about the women, maternal, cervix, breast. Then another topic of my presentation was a triple threat. And what is a triple threat? Mentioned already, new HIV infections, most common in young girls and pregnant women. Pregnancy and postpartum is really a big, big risk area for new infections. Gender-based violence, adolescent pregnancies. And Kilifi is one of the counties really working hard in this area. You have already strategies for HIV, adolescent health, but now we have to implement them. And the triple threat, UN agencies are joining, they are calling upon everyone to join, and Kenya has launched a very ambitious plan in 24 to end it in 27, but nothing has happened since 24. I'm going to skip these ones. These are my great teams, they are all here. I just want to say they are working very hard, because my number one was quality of care in childbirth. Number two was family planning. Number three was integrating innovation and technology. So here you see new technology and ultrasound and new technology and AI. We don't have time to go in the details. Evidence-based advocacy is needed for the policy reforms. We made partnerships, as you can see here, with the governor and Waziri. We were involved since more than 10 years in community health, in developing the strategic plans for the government. And we were even, and now just I want to end, I want to just show you, and it's outside there, a new program on sexual and reproductive health and rights. Because in the current political and financing ecosystem, there is almost no money anymore for SRHR. It's really gone down. So we are happy to say that the Canadian government is supporting Kilifi with the program called Strides. It's Kilifi County in the lead, supported by the Aga Khan Foundation, Aga Khan University Health Services, and partners such as ICRH and Moving the Goalpost. One of the things there is also something you can see outside, a Pioneer mobile app, which is really top-notch technology, because in Kenya there are 6 labs who can provide this technology for like new infections, mpox, whatever, and there is number 7 that is a mobile one. So 6 are in the facilities. This one can go around to any part of the country. And we did, when we launched in Ganze, the program last month, we offered this screening for cervix cancer with gene expert, and there were immediately, the results are known immediately. Out of 36 tests done, 11 were positive for cancer, for oncogenic HPV. So to end, I think we were involved in the very first health research forum in 2017, I think, or 18. First time that Ministry of Health and the research communities came together and we learned a lot. Second, the Kilifi Scientific County Symposium was in 2023, and today we are now in the third one. So in conclusion, I would say a big thank you. Thanks to Kilifi County leadership, and congrats for moving this agenda forward together with partners and for organizing this symposium. Congrats also to Kilifi County, and I know Waziri is there, but our director is here to really working hard with everyone to the progress, and more has to be done, but the progress has been made in, we always say Kilifi has the highest number of teenage pregnancies. I'm not sure about it. I think we have managed to take it down, and we know how to do it, because it was really great result, and I hope that Kilifi, because Kenya is making less noise about child marriage, less noise about all these young girls who get pregnant, teenage moms, so many, we hardly talk about it a bit, and we make more noise about that than availing contraceptives for the young girls. We could avoid so many teenage pregnancies if the young girls also had access to contraception. And I think that's really something, of course that's a policy and politics, but that we really should. Why don't we care about all these child marriages? What do we say about the young girls? And even worse now, because here in the region, and not only Kilifi, a lot of the young girls who get pregnant below 18, can they access SHA? Many of them don't have an ID. So we see that maternal problems, HIV and neonates, is going up. Because we have less pregnant women, and surely the very vulnerable, the young girls, who have more problems accessing healthcare than ever before. So we should also target these ones. We want to appreciate recognizing these challenges. And as I said already this morning once or twice, calling upon all the partners who are here and those who are not here to really work together under the leadership of Kilifi County government, and in particular Department of Health, but of course with all the other departments, because together we are always saying, if you want to go far, if you want to go fast, but I think together we can go far and fast. Thank you.
Thank you so much, Prof, for sharing so much of your wisdom with us. I'm sure there's a lot more, it's just that we don't have time for it. Okay, so in the interest of time, for anyone who has questions for Prof, we'll keep those until the end of the question session at the end of the midway in this session. Sorry, there's so much going on. Anyway, so we'll welcome a speaker who was supposed to talk tomorrow, but because she will not be in tomorrow, she will come and give her talk now. This is appointed to those who are judging. This fits in the plenary session 4 for tomorrow. So please, as you judge this one in that section. Her name is Noni Mumba, and she's the head of engagement at Kemri Wellcome Trust Research Program. Karibu, Noni. Asante sana, Nancy. Good afternoon, everyone. Hi. Please wave at me. Thank you. I just want to be sure you're all awake. So as Nancy has rightly put it, first of all, I'm not Gladys Sanga. As she said, my name is Noni. I'm making the presentation on behalf of Gladys. She was supposed to do the presentation tomorrow. She got an impromptu but urgent meeting in Nairobi that she needs to attend to. So I'll do the presentation together with her. Coming off the talk by Prof. Malin, talking about maternal and adolescent health. This is a bit out of that topic, but it's still related because it's about populations being able to access health services during extreme weather. And one of those very important populations is women, especially women who are pregnant, young children below the ages of 5, and how they are able to access. So it's related to just the talk that has just ended. This is work that is embedded within a project that is in its second year now, called the New Risk Project, a novel extreme weather risk insurance system for Kenya. That's the full name, implementing it as Kemri Wellcome in collaboration with the University of Oxford. So I'm presenting some findings from work that we have been undertaking in the course of this year, just finding out community members' perceptions about extreme weather related to climate change, and some of the coping strategies that they have to ensure that they can still access health services when extreme weather events happen. So we've been undertaking this work in the 7 sub-counties of Kilifi, all the 7 sub-counties, talking to facility management committee members, talking to community health promoters, and talking to community members about extreme weather events and how they manage them. So the outline of my presentation, I'll just give you a brief introduction, what our objectives are for the work that we've been doing, the methods that we've used in collecting data, some of the findings that we have gotten, our learnings, and then, yeah. So we know that climate change, everybody now is talking about climate change. It is adversely affecting human health. But more so we saw in the recent past, I think people might be aware of the cyclone. I don't know if it was a cyclone, but the thing that happened in Malawi, where a whole region was completely flooded and health systems were completely devastated. We've had the same in Kenya here, around 2023, 2024, where we had change is affecting health and affecting health systems and health services. We know that community members are also affected when health facilities are not able to offer services. Community and health services are also affected. Some of the best approaches that have been put out there in terms of being able to mitigate against the effects is partnering with community members. That's what we are trying to do, to see what do community members know, what are they currently doing, and how can we best partner with them. So the extent to which community priorities are able to inform the development of solutions is not yet known, especially in the area of climate and extreme weather. So our objective for this work was to examine community perspectives towards extreme weather, health system mitigation strategies, and how to communicate climate risk data and eventually co-create health system risk mitigation together with community members and other stakeholders within the health sector. So we have 3 objectives. The work that I'm going to be, the findings that I'm going to be sharing relate mostly to Objective 1 and Objective 2, the first 2 bullets, just exploring community understanding of climate change and extreme weather and their perceptions, and also just trying to understand what their priorities are related to climate change and health. So we undertook some piece of work. We conducted some community consultations We developed a tool, and then we used the tool to do community consultations. As you can see there, we did 14 consultations across, as I've said, the 7 sub-counties of Kilifi County, and I've already said that we talked to CHPs, community members, and facility management committee members and facility boards for larger hospitals. So on to some of our findings. According to the groups that we spoke to, the community members, FMCs, CHPs, what they think is causing or can be causing climate change is industries, for one, deforestation, and for some they felt it's actually a punishment from God. So from that quote down there, I had people saying that climate change is a punishment from God, that we've committed so many sins that God is punishing us. And this was really related to some of the atrocities that has happened, for example, in Shakahola, the things that have happened in that region. People felt we are doing so much ill to one another that God is taking away our rain and changing the climate. And as you can see on that photo, the deforestation was related to overgrazing. You can see camels there. There's lots of, nowadays, lots and lots of herds of cows in Kilifi County. And then, of course, you can see the border there with charcoal. So charcoal burning being another source of climate change. So in terms of extreme weather effects to health facilities, we asked the community members what do they think some of the effects of extreme weather events to health facilities. So they talked about reduced access to health services. So when there's an extreme weather event like flooding, people are not able to access health services. They're not able to attend to health facility. They cannot reach the place because of flooding. Increased patient workload and straining of the limited resources. So they talked about limited health workforce and the fact that when an extreme weather event occurs and there's a surge of patients at the health facility, then the facility is not able to cope. So in terms of coping strategies, we asked them what do they currently do. And they talked about adopting alternative service delivery methods. For example, one facility management committee member said there were problems at our facility caused by the floods to the extent that it had to be closed and the people had to be treated outside. So a mobile clinic was brought in because the place was completely flooded. Some other coping strategies is offering first aid. So community health promoters said that they are able to step in and provide some basic services in the population when an extreme weather event has occurred and people are not able to reach the facility. For community members, they said what they do when extreme weather events happen is that some of them have been hosting healthcare workers so that they don't have to cross a river and go back to their home. They stay within the village so that they can be able, and they are hosted by the community members there. In terms of learnings, one of the things that we learned, one of the first questions we were asking them was, what are the priorities of community members in your region? And we got the sense that climate change was not the top of their minds. Rather, they would share things like, we don't have access to water, our road systems are very poor, we don't have medicines. Those are the kind of things, the very immediate needs for them are what are a priority for them, as opposed to climate change. Another learning was that we may feel like extreme weather events happen and maybe people are stranded, but in actual fact, community members team up with the healthcare workers and they are able actually to devise coping strategies so that they can move forward with giving health services to community members. And then they felt that there isn't really guidance from the top in terms of being able to guide them on what can they do when extreme weather events happen. And that they are willing to participate in development and strengthening of adaptive capacity. Thank you for listening to me. Santeni-san. Thank you, Noni. In the interest of time, our next speaker is going to be Benjamin Kihika, who is a monitoring and evaluation officer from Helen Keller International. Karibu sana, Ben.
Thank you so much, Nancy. Good afternoon. Yeah, good afternoon. Thank you so much for this opportunity. I thank the county team and the management and everyone who is here. Allow me to... Okay.
Maybe put it close.
Okay. So thank you so much for this opportunity. First, thank the county for arranging this and also for giving me this opportunity to present this to you guys. Thank you so much. Yeah. So my topic is on barriers and promoters, specifically looking at breastfeeding among the caregivers. Our target population in this study, we were looking at the children of age 0 to 23 months, and we did this in all the 7 sub-counties across Kilifi, where we had interviews at the household level, as you will see. And it falls under that theme. So this is the outline of the presentation. Give a small background. I'll also give an objective, which basically I've mentioned, the methodology that we used when we were doing this research, and then we talk about the results and some of the conclusions. So as we all know, the stunting at the national level, Kenya to be specific, 18% of children remain stunted, and this is according to the KDHS. And I know we also know that Kilifi County is the #1 in terms of stunting, and we're talking about children that are stunted. These are the under 5s. And we have interventions that are related to combating this, and we know all the reasons that could cause stunting, but some of the interventions, specifically those that are related to nutrition, that we have ongoing, from breastfeeding and promotion at the facility level, at the community level, and the continuation of the same up to the age of 2 years for children, that can greatly reduce the mortality rates among the children. And we acknowledge that this data is available at the county level, majorly through the KDHS, but the knowledge and practices, the attitudes among the caregivers around breastfeeding is yet or is not available, especially at the sub-county level. So these were some of the bases in terms of why we did this study. So one of the objectives, I paint the broader objective, was to assess the promoters and the barriers to early initiation, and these among the caregivers of the children in that age cohort that I mentioned. So the study, in terms of the methodology, we adopted a mixed method design where we had interviews at the household level. That's for the quantitative data that we did collect. We also had interviews with several groups, or I would call them stakeholders, from the sub-county, the county teams, and largely talking to CNCs and healthcare workers who are seeing these caregivers or these mothers at the facility levels for the qualitative data sets. And we also had a number of KIIs with specific stakeholders. So we got to interview mothers, we got to interview when I say mothers, it's the adult mothers, the young mothers. We also got to talk to grandfathers. We also got to talk to community health promoters in those focus group discussions, just to see their views around breastfeeding. So on the sampling, or if I would say the sample size and the target population, I mentioned we were talking to caregivers. These are the mothers of children 0 to 23 months, and we had a 2-stage in terms of the sampling design. We used enough or SMART to derive our sample size, where the first stage was to select clusters, and these were villages distributed across all the 7 sub-counties that we have in Kilifi, and the second stage in that process was to randomly select households that had been listed, and the eligibility was a household that has a child who is within that age cohort. So eventually, we targeted to reach to 928 households, and those were 46 point something clusters that we rounded off to 47 clusters distributed across our sub-counties that we targeted for this data collection. In terms of the results, we did manage to reach 940 households, where in these households we managed to reach to caregivers of around 938 children. And you'll see for the age cohort, and that's across the age cohort, 0 to 23 months, we had around 30% of these children who are aged 0 to 5 months, which is around 281 children. Now, I will speak into the breastfeeding outcomes, which were of our key concern, And greatly to note, for early initiation, and this is the first column, we were at 70%, which is higher than the national level, which is, I would say it's a great achievement. And across the three indicators or the three outcomes that we looked at, the early initiation, which is in a child being initiated on breastfeeding within 1 hour, we were at 70%, which is above the national, which is 60. And then for exclusive breastfeeding, we want the children to continue breastfeeding for up to the age of 6 months, we are at 86%, which is also above the KDHS national outcomes. And still for continued breastfeeding, we were at 77%, which is also slightly above the KDHS, which is around 61%. Now, for the knowledge, and this specifically for caregivers, most of the caregivers that we spoke to, around 85% of this, they believe that a child should be breastfed immediately they are born, or a child should be put to breast immediately after birth, which is a good thing. And we will see how the knowledge among the caregivers, and I would also want to thank maybe the healthcare workers at the facilities for cascading the same. We have knowledge and we have caregivers that are aware of why breastfeeding is important, and most of them have a good opinion of the breastfeeding practices. Now, however, in terms of breastfeeding support, when a caregiver comes to the facility, delivers, and the intention of they want to be supported in terms of initiating breastfeeding, we had around 41% of caregivers that did not receive support at all. So we have great efforts in certain steps, and also we have other areas that we need to work on. Just to highlight the conclusions in 2 bit, connected to the high performances across the breastfeeding indicators, we would acknowledge the effort of the BFHI activities across the counties, where we have AYCN messages being passed to mothers from different forums at the facility level and even at the community level. And our intention in terms of the recommendation is for that to be sustained and to be cascaded to all the community health units. And you can see we spoke about the factors that are promoting the good uptake of breastfeeding practices, from health education, which is key, and also the sensitization that continues as mothers visit for ANC clinics. And in terms of the barriers, we have the lack of support, which came out clearly from around 41% of the respondents that we talked to. So those are recommendations. And maybe just to mention, the breastfeeding or the early initiation was okay at 70%, which we spoke about. But when you look at children that were exclusively breastfed, there was an issue. So we had exclusive breastfeeding that was okay, and it is in the first 3 months. When a child is 4 months, 5 months, and 6 months, the exclusive breastfeeding rates were slowly going down. So we would want to improve on that sector. Then the coverage of exclusive breastfeeding is good, but we are not yet at the 90%, which is recommended by WHO, and it's also seen to reduce the mortality that Prof talked about earlier on, and the scale-up of the community health activities across all the units. I suppose my presentation ends there. Great thanks to my team at Helen Keller and also the county government that collaborated with this study. Thank you so much.
Thank you, Ben. We need to confirm whether Husna Mwaka is here. Okay. Melanie Yolum. So you're next. Anyone who has a presentation within this session, please come to the front so we can save time. So, Melanie, please take it on. Did I hear a yes? I thought I had a yes. Oh, you're coming. Karibu. Anyone else who has a presentation, please come sit at the front so we can save time. Melanie? Yes, please. Take it on.
Good afternoon. My name is Abigail Sidi. Sorry for the miscommunication. I'm doing a presentation on menstrual health hygiene management. I am from International Center for Reproductive Health, Kenya. Yeah, good start.
You're going back. Yeah, keep going, keep going. Yes.
Okay, thank you so much. So our topic is exploring menstrual health and hygiene practices among adolescents 10 to 19 years. This was a national survey conducted in 8 counties across the 47 in Kenya. So, sorry, my eyesight is poor.
Oh, you can't see this one.
Okay, this is much better. Okay. So, so we did a small introduction about who an adolescent is. For this study, we focused on persons between the age of 10 to 19, and we described MENAC as a biological milestone for an adolescent girl, and it marks the onset of the reproductive phase. So we know despite having a lot of potential, there is heightened vulnerabilities, especially in low and middle income countries. And in Kenya, the last study that was conducted, about 54%, with 58% in rural and 53% in urban, still face challenges in accessing MHH products. So this was our problem statement. We had a deep dive into the current documents that Kenya currently has. So we looked at the menstrual hygiene policy, the strategy, reproductive health policy, as well as the adolescent sexual reproductive health policy. And then also another challenge that we had in our problem statement was most of the focus is normally on menstrual hygiene with a mismatch in the menstrual health component. And you see this is normally integrated into sexual and reproductive health and services. And then there's also limited understanding on the influence of MHM policies and programs on adolescent girls and their experiences. So these were our objectives. One, to just understand the menstrual health hygiene practices among adolescents, and then to review the extent to which the policies that we have in Kenya have been implemented, both in schools and within the communities and other relevant settings, and just look at vulnerabilities that adolescent girls face. So this was our methodology. It was a mixed method approach. We had a desk review to review the documents, and then we had a quantitative with a sample size of 1392 for the entire country. This one targeted adolescents using a household survey, and then we also had adolescents with disabilities taking 10% of the total sample size, and then we had both in and out of school adolescents. And then for the qualitative, we had IDIs, FGDs, and KIIs with adolescent boys and girls, parents and caregivers, teachers, hygiene promotion officers, reproductive health coordinators, and both county and national stakeholders. So this was the distribution in terms of the study geography. We were in those 8 sub-counties: Kitui, Garissa, Marsabit, West Pokot, Bungoma, Homa Bay, and Nakuru, representing all the 6 blocks in Kenya. And these are our findings. So averagely, the age to start menstruation for most of the girls was 12 years. And then in addition, 20% were between the age of 10 to 19. The majority, which is 49%, were between the ages of 15 to 17, and then the remaining was 18 to 19 years. And then at the time of the survey, majority were in secondary school, representing 56%. We had about 30% in primary level and about 3% in tertiary. And then of the total sample size, we had 10.6, which represented adolescents with disabilities, those with hearing, physical, and visual. And then in terms of knowledge of menstruation overall, 74.4 girls had prior knowledge of menstruation before they started receiving their monthly period. And then among those with disabilities, only about 53.1 had knowledge. So you can see the disparities when you compare adolescents without disabilities and those with disabilities. And then most of the adolescents reported receiving this knowledge from schools. And in schools, we also went further to see if this education is provided to both boys and girls, or it's just for girls. So for many of the schools, 60% this education is given to girls only. And then about 29% give it to both boys and girls. And then we had about 8.9% reporting they didn't receive this kind of education in school. And then in terms of the practices, this is what we looked at. Mostly for the change of menstrual products was mostly at the pit latrines. And then frequency of change, majority reported changing thrice, but we also, this was followed closely by adolescents who reported changing their products twice, and then we had once, and some, for a very few percentage, more than 3 times. And then we looked at the access to water, the component of menstrual hygiene. So we asked if they had access to both water and soap. So this was below average at 45.3, the ones who reported having both water and soap. And then 30% had only access to soap but did not have water. And then another 23% reported they didn't have access to either soap or water. And then in terms of what most adolescents would use, majority said they use disposable pads, but again they had difficulties in accessing them. And then we had other products that were used, such as pieces of cloth, and then we had underwear, panty, and also cotton wool. In some areas, like in Marsabit, we also had, and West Pokot, we also had adolescents talking about pieces of leaves and things like that, and blankets. And then overall access to menstrual products, so 54.4 reported no difficulty in accessing. This shows that we've made some strides from the initial study that was done, that was at around 45%. And then, so the difficulty in access was as closely associated with affordability. So most adolescents said that these products are quite expensive. And then we looked at the health-seeking behavior. So adolescents reported receiving some menstrual health complications like heavy bleeding. We also had pelvic cramps and things like that. But of those who cited those, majority did not seek care. And the ones who sought care, only 35.3 are the ones who sought care from proper public health facilities. Yeah, so this I've already talked about. So the bigger bracket is the one that reported receiving pelvic care, though we also had adolescents citing excessive bleeding, back pain, and things like that. So the kind of management that was used was pain relievers, hot water. Some of them took a rest, it means missing school and things like that. And then we also looked at vulnerabilities now for adolescents regarding menstrual health and linking it to urogenital infections for those who use unconventional products. And then we also linked the same to transactional sex, because most of the adolescents also cited that these products were often unaffordable. Yeah, and then these are our recommendations to raise awareness, having multi-sectoral frameworks, also looking at gender mainstreaming and social behavior change communication programs that target adolescents and communities, and then strengthening the specialized menstrual support, especially for girls with disability, for us to have more inclusion. Yeah, and strengthening and sustaining the free sanitary towels that is already currently in our policies. Thank you.
Thank you, CD, and sorry for calling you by the wrong name in the beginning. Our next presenter is Margaret Hanselman. I hope I said that correctly. Yeah. Okay, karibu sana, take it on. Asante.
Good morning. Margaret Hanselman. So I'm Margaret Hanselman. I hope that's easy on your tongue. From the Center of Excellence in Women and Child Health, a department within the Aga Khan University. So I was really hoping that the speakers before me would have set the ground so that I can skip some of my introduction, but unfortunately I'll have to start from the beginning. Okay, so I'll be presenting, So I'll be presenting our preliminary findings on a research that is centered on adolescent health, especially mental health, and it was a co-design intervention being implemented in 2 countries, that is Mozambique and Kenya. So it has the acronym INSPIRE. So INSPIRE is, thought of when our PI was thinking of an intervention, when she was trying to, I'm sorry. Okay, I usually get a little bit cold feet when I start. So when our PI was trying to lay the foundation on how to, for the funding, there are 2 things that stuck out for her. One of it was adolescent pregnancy. So adolescent is a stage whereby of vulnerability, heightened vulnerability and transition from child to adulthood. And during that time also, these adolescents experience a number of changes, be it physical, be it physiological, and also at times it impacts the mental health. Then let's think about pregnancies too. So pregnancy is also a stage of vulnerability whereby a woman experiences a lot of changes, physical, physiological, and also impacts the mental health. So when in 2020, when this funding when this protocol was being written, Mozambique was 4th highest in adolescent pregnancy, while Kenya was 10th in absolute numbers, because we have a high population of that demographic. And 1 in 3 of pregnant adolescents had experienced a mental disorder during pregnancy or the perinatal period. And we all know that mental health status of a mother also impacts either negatively or positively on the mother herself and also on the pregnancy outcomes. That is also the child. So it is said that we are expecting adolescent pregnancies in Africa to do what? To shoot up in the future. And when you think about interventions which are there, mostly when you think of interventions for mental health, not only mental health, but also in other spaces, you think about approaching the experts, either the clinicians or the researchers, right? But INSPIRE did it a bit differently. We tried and this is not a political statement, but I usually call it bottom up. So whereby we try and engage the community, and in this case, INSPIRE engage the adolescent girls, who are our target group, the community influencers, and also service providers to help us co-design an intervention. So the aim of INSPIRE is to work with adolescent girls, their families, and communities to co-develop and evaluate an intervention to improve adolescent perinatal mental health through human-centered design, systems thinking, and implementation science. So INSPIRE was done in 2 phases. The first phase, we co-developed the intervention, and the second phase, we evaluated the prototype that was developed in phase 1. So in all this process, we've engaged, here it says 163, but if we include also Mozambique, it's above 200 stakeholders. It was implemented between 20 and 24. And within this engagement, we engage adolescent girls, that is pregnant adolescent girls between the years of 15 and 19, young women, that is 20 to 21 years who had a child who was under 1 year old, meaning that she was pregnant during the adolescent period. And then we also engage their partners and their family members, service providers, both at community level and also facility level, and also the community influencers, like religious leaders, teachers, etc. So during this, using the human-centered design, we had iterative workshops whereby we, through qualitative interviews, photo voices, spiral walks, we got to know the gaps, the needs, and opportunities of these adolescent girls during the perinatal period. We also had interviews, focused group discussions, and also qualitative interviews, that is the KIIs with the service providers and community influencers, to get to know what their experiences are with pregnant adolescents. So from there, a number of themes came up. We generated a number of themes. And during this iterative workshop, we identified the priority themes which later helped us create the content and also the delivery strategy of the intervention. So the identified priorities were this. So there was the dealing with stigma when they were pregnant, getting good antenatal care, there was GBV, there was return to school, having good relationships with the family and their friends, knowing how to care for the baby, preventing future pregnancies, and also having enough money to pay for their essentials. Because remember, these are adolescents. Some of them, most of them have dropped from school. No one knows how to get money, how to get an income to take care of themselves and their babies. So these were the identified priorities, which were then designed to make up an intervention. We call it like an enhanced ANC intervention. Lord. So this is the proposed intervention. So in Mozambique, they call it Kutandizana, and in Kenya, we call it Malkia wa Malengo. These names were given to adolescent girls. So